My name is Dr. Dipti Bhakta, and I'm a psychiatrist here in Northern California. So I have a practice in Pleasanton, and I received my medical degree from UCLA back in 1993. You have patients that usually they describe an incident that happened, not necessarily recently, but it could have been in the distant past in their childhood, where felt a sense of terror, impending doom, some sort of threat. And then after the event passes, sometimes it's months, sometimes it's years later, they start reliving the trauma. So examples of trauma are of course, like vets who have been in wars, like witnessing a crime or being the victim of a crime or an assault, sexual trauma, whether it's one time or chronic. Those are very common types of trauma that patients come to see me for. And usually it's because it's happened and then they thought that they put it behind them, and then there's a trigger. So for example, I might see someone who had some sexual trauma, but then they were doing well, and then the flashbacks came back in their life when they had, let's say, the birth of their daughter. And then it reminds the female patient of what she went through and how she wants to protect this person. So it's often a delayed reaction. So a lot of times when people go through acute trauma, they think they go through it. Let's say they were in an accident and they witnessed someone who died, and they talk to their family, and then they go to the funeral and they feel better and they think they're okay. But sometimes you have to still talk about it in more depth. And many people don't do that. So then years later, there's another incident that just rekindles the emotions that didn't get dealt with. And that actually also even expands on to grief work. So for example, when someone's had a loss of a parent, they may not feel depression and anxiety or sleeplessness immediately, but then, months later, they can feel the symptoms emerge of depression and anxiety. So it's not PTSD, but it still is a similar concept of a delayed response. It's human nature that if you've experienced some kind of trauma, you want to just pull yourself up by the bootstraps and say, it happened, but I'm safe and it's okay. I'm out of danger. So let me just move on. So people just shut it out. So we call that suppression, So they suppress the memories. They say it's behind me. It's kind of, in lay terms, you sweep it under the rug. So that's very common. But then what happens is the heart racing, the tension that the person felt in the moment of the trauma doesn't get dealt with. But the body physiologically sometimes still has those emotions that start coming out in different ways. So sometimes people get irritable with their spouse or with their kids, and it's really because of issues that weren't dealt with. So when people start coming to psychotherapy or come in for an assessment, my job is to try to help them figure out why they're having current symptoms, and sometimes they don't even make the connection. And so when I say it's PTSD, they're a little bit shocked in the beginning, but then it starts making sense, because a lot of the work as a psychiatrist is psychoeducation. Really explaining patterns, and insight alone can really take people a long way. Just knowing that this is what it is, giving it a label, makes them feel okay. It stands for post-traumatic stress disorder, and the key word is post. So the post means you have a trauma, but it happened, the symptoms of the trauma occur months or years later. The person has to have had a trauma or witnessed a trauma, and then the symptoms are hypervigilance, hyperarousal, flashbacks, nightmares, a lot of anxiety, a lot of panic, and sometimes a sense of numbness about the world, people feeling like they're in a daze and questioning their existence, and a lot of hopelessness. And the flashbacks are sometimes accompanied by nightmares, and so people are having a lot of insomnia. So a lot of times they initially present as just depression or anxiety, but then when there's a trauma linked to it from the past, that's how you can tie in the diagnosis of PTSD. They've done, retrospective analysis and data and studied people who have been traumatized, and then they look at them, like let's say the Waco incident, and then they look at them 5 years later or a certain amount of time later, and they see who's living with symptoms of PTSD, meaning they can't sleep, they've lost their job, they have they've lost their relationships because of the paranoia and the anxiety and the constant panic attacks. Many of them, they've lost their ability to function in the sense that they can't keep down a job because they're always in this hypervigilant state of anxiety. So who are the people that fall into the category that become disabled from it? And then who are the people that quote unquote live normal lives? A lot of it depends on resiliency. So there's some people who take the trauma that they had and they decide to do something very impactful. For example, they're doing a TED Talk about their own experiences, or they write a book, or they decide to go to high schools and talk about lessons learned. It's like self-healing, self-therapy. So they often do very well because they found a way to channel it into something productive. So that's a form of resiliency. Other people, the way they channel the trauma is through some healthy mechanism to get the aggression out. So, for example, becoming a football player, so you get to tackle and take the aggression out on the field, but not, do it in your day-to-day life. But then there's others who don't have healthy channels or haven't figured out how to find those. And they're the ones who often succumb to a lot of anxiety. And instead of, let's say, taking the aggression out on, in a sporting event, they might decide to get involved with a gang, something where they could get into legal trouble because they have all this aggression, but they don't know how to take it out in a healthy way. The other factor about background is, if you grow up where there's a lot of support for mental health and your family is open-minded to understanding feelings and talking about that really helps. So, so your environment helps, education helps. If you have learned about it in some form or another, you might say, okay, this is acceptable to get help. So it depends on the trauma, right? So if someone's had trauma where they saw fire at their school, that's very different than the person who was at Columbine. It depends on the degree of the trauma. If you get the treatment with a professional who's trained, so a psychotherapist or a psychiatrist, recovery can be within, it's hard to put a number on it, but I'd say certainly within a year. People get a chance to talk about what happened to them, their experience. The therapist then helps them. Some of it is psychoeducation. Some of it is what we call cognitive behavioral therapy, where techniques you use to help them, try to handle the situation a little differently. And it's a lot of it is trial and error, but usually I'd say within a year, people feel a lot better. But I think long-term, no one fully recovers. There's always the memories, but it's about how you quickly, if you're about to have a panic attack, how do you quickly turn it off? So over time, hopefully the frequency and the intensity of the panic attacks go down, but there's always a chance that you might have one, even if it's just once or twice a year.
It's better than every day.
Absolutely. So a lot of patients I see, they're having panic attacks several times a week. And by the time they're done with treatment, they might say, I think I get a little panicky, but it's certainly not the intensity it used to be. And the frequency is maybe once every 2 months or once every even 3 or 4 months. And often the trauma or the anxiety, gets stirred up maybe on an anniversary of whatever the trauma was. And so it's maybe just over time, it's just once a year. I prefer to try psychotherapy first for a good, probably a good 3 to 4 months to see if psychotherapy alone will help, because I do think it helps in and of itself. But then when we're kind of hitting some obstacles and not, the physical symptoms of the anxiety and the insomnia is just too much, where the therapy hasn't really made enough of a dent, that's when I think a medication intervention is worth doing, because there are plenty of people who I think could respond to psychotherapy alone. But I'm not a proponent for medication management only. I think that should always be in adjunct with psychotherapy, because sometimes then you get the person who's just looking for a pill to make them feel better, and then they're not dealing with the feelings. So that's really avoiding what's making them feel traumatized. So you really, especially with PTSD, you really have to identify what the traumas were, because otherwise you can actually get into trouble where you might get a hold of benzodiazepines, for example, and those are tranquilizers, and then they're just taking that to numb out the emotions, and that's not healthy. I think it's absolutely runs with a lot of other diagnoses. There's a lot of comorbidity with substance abuse and PTSD. Particularly, we have a lot more research in the VA population. The veterans who've come back from wars, they often first come back, might not go directly to mental health, but they go to drinking. So they go to the bottle. So it starts often with alcohol. Sometimes that gateways into other drugs, and they're trying some form of self-medication to numb out the flashbacks, the negative memories, and sometimes the panic. And alcohol, to be honest, it works initially, but then it's not regulated. It causes more problems. Alcohol in and of itself, long-term use, is a depressant, so you wind up having more problems. But in the beginning, that first half an hour of having the drink, it really can calm the nerves down. So, and that's what a lot of these people who have PTSD might first turn to. So a lot of comorbidity with substance, in terms of PTSD and polysubstance abuse. And then you also see PTSD. If you look at the signs and symptoms of PTSD, you also have people who it looks like depression and anxiety. There's a lot of overlap, which is very interesting because the medications used for depression, anxiety, and PTSD are pretty much the same, because in all of them, there's a heightened state of anxiety and stress. And so medicines like the serotonin reuptake inhibitors really can help reduce that. Get the help. So how do you get the help? You start off with primary care physician. Sometimes, that's the best person. That's kind of your physician who hopefully has known you for a long time. You share with them what you're going through, and they can give you the referral. I say, what have you got to lose? It's worth talking to someone. Give it a shot. See if you get some improvement. I certainly don't think talking to a professional is going to do any harm. If anything, if you hear that there's an opportunity to get well, why not take it? Sometimes people don't, they're not as comfortable with their primary doctor. They don't have one. Then there's a lot of resources, organizations like NAMI, or go to psychologytoday.com and put in your zip code and get a filter out for people who specialize in PTSD. And there's a lot of resources out there to get the help. And also, if you have good family support that's encouraging of getting help, then you're more likely to do it. In life, you have to look at it and see what you're handed, and then try to shape it and live your best life, even if there's been traumas in it. You just have to learn to live with it and make yourself stronger despite all the pain and suffering. Do I choose to live my life and go on to, let's say, higher education, or do I decide I'm not, I've been victimized and therefore I'm not going to work, and I'm going to look for people to take care of me. So I think, if you love yourself, you'll take care of yourself. And so I think it echoes. And often I'm helping people to remind them, look, if you were abused, it wasn't your fault. But the facts are that it happened. So we can't reverse the past, but we can change what happens in your present and then moving forward in the future. People have to realize, look, you can take the future into your own hands because you have free will.
Hey everyone, hope you enjoyed the video. I want to thank Dr. Bhakta for joining me and sharing her time and expertise. I enjoyed that, thought that was fascinating, and I hope you did too. If you have any other questions or mental health topics that you'd like to see discussed, just let me know and I'll try to find someone who has that specialty, and we'll go ahead and talk about it. If you like this music that's playing right now, if it's your jam, you can go ahead and check out a link in the description to my sister's Instagram page. She composed the music, and you'll find more of her work over there. Until next time, everyone, stay safe, stay healthy, and keep cool. This has been Man of Nothing.